at the boil at the other one. So let's keep going. All right, so now this patient comes in to see you, and you see this on this man's face. It's indurated, it's red, it's superficial, it's sharp borders affecting the upper dermis. What does this patient have? What is this? Well, if you said erysipelas, you were correct. That's exactly what this poor guy has. It's basically a cellulitis, but just it's more superficial. And how would you treat this patient? Well, if you said Keflex, which is a cephalosporin, or penicillin, diclo, you were correct. And if they're allergic, you could also use macrolide, and you could apply some Bactrim if you really wanted to. All right, so now this person comes in, and you see this on their skin. It's waxy, shiny, dome-shaped. It's often flesh-colored. What is this? Yep, molluscum, right? Molluscum. That's exactly what this is. It's viral, it's self-limiting often, usually it's no big deal other than the appearance of it. You could use some TCA, some crypto to remove it. It is not okay if you find it in a child in their private areas. Then you want to be worried, okay? So this is another shiny differential diagnosis. Remember, we already talked about genital warts earlier, and then this. All right, so now this person comes in, and they have a high fever, and chills, and a headache, nausea, vomiting, and some eye issues like photophobia, and they tell you the rash started on their hands and their feet, and their soles of the feet, and then they went to the trunk, okay? Maybe it's itchy, maybe it's painful. What does this patient have? Also, they've just recently hiked in the Rocky Mountains. Well, if you said Rocky Mountain spotted fever, you are correct, okay? And how do we treat this? Doxy. We give them doxy, okay? Even if it's a child, even if they're under 8, we are still going to give them doxy, right? This is that exception I was talking about, because this could turn fatal, right? Even if they're pregnant, we can give them doxy. That's what the CDC says, okay? It's where we care about their life more than teeth being discolored and such. All right, so now this lady comes in and she tells you that she's been wearing this new beautiful gold necklace she got for her birthday, and she got this. What is this? Well, contact dermatitis is I hope what you said, right? Typical contact dermatitis. And how do you treat this? Topical steroids. We love our topical steroids and things like this. Don't really necessarily have to worry about which topical steroid, just remember topical steroids. All right, so now this person comes in, and not necessarily a child, could be an adult, and you see these things on the flexor areas. What is this? Well, hopefully you said atopic dermatitis, okay? Atopic dermatitis. And again, what do we want to treat this with? Topical steroids. We just love our topical steroids, guys, right? And what are the 2 diseases are often associated with atopic dermatitis? Hopefully you said asthma and allergies, okay? Remember these things. All right, let's move on to this one. So, what is this scaly, patchy, silvery looking thing that can bleed easily? What is this? Often found at extensor areas. Also, when it bleeds, it's called the Auspich sign. Well, if you said psoriasis, you were correct, okay? And how do we treat psoriasis? Topical steroids again. We love our topical steroids, right, guys? But what else can we do? We can do some phototherapy, right? We can apply some coal tar, okay? So that's what it differs from the other 2 we talked about, where we use topical steroids for all of them, but for this one we also can use coal tar, okay? All right. All right, so now this gentleman comes in, and he's older, and he's been out in the sun his whole life, and you see these dry, round, pinkish lesions on his sun-exposed areas, right? And what do you think this is? What are these called? Well, if you said actinic keratosis or AK, you were correct, okay? So again, remember you guys, the exam is all about the typical textbook signs and symptoms of things. So you gotta know this, okay? You have to be able to not necessarily always see it on a picture, but how it's described. And how would you treat this patient? Can you put on that? Well, hopefully you said 5FU, 5FU. Cryotherapy is also another option, but that's how you can treat this. And why is it important to treat this? Well, because it can turn into cancer. And what kind of cancer? Hopefully you're thinking squamous cell carcinoma, okay? So AK can turn into squamous cell carcinoma. All right, so now this patient, older patient comes in, and they have these non-painful, maybe brown, maybe black, maybe tan plaques that have a paste-on appearance, okay? What is this? Well, hopefully you said seborrheic keratosis, SK. This is benign. This is no big deal. Yes, we can do some things. We can do things about it to remove it because it's not that pretty, but it's not as dangerous as the previous picture I showed you, the AK that could turn into squamous cell. Okay, so it's important to differentiate the it's important for you to know the differences between these two and how they're described. All right, so now this person comes in and they have this waxy, shiny, pearly, dome-shaped looking thing on the body, and there's some visible vessels. What are you thinking? Well, hopefully you're thinking basal cell carcinoma and you're a little bit worried, right? This is typical basal cell carcinoma. This is the most common one. About 80% of skin cancers are this. So we want to biopsy and we want to refer them out, okay? So this is our third shiny condition I showed you, okay? We already saw those genital warts that were shiny, we saw the molluscum that was shiny, and then we're seeing this that is shiny. They're all differential diagnoses of each other. All right, so now an older patient comes in and they have this thing, and it's slow growing. They tell you it's been there for a long time, and it doesn't hurt, and it's dry and scaly, and maybe it looks like an ulcer, maybe it's ulcerating, maybe it's not. It also bleeds very easily, and it's just been there for a long time. What are you thinking? Well, I hope you are thinking squamous cell carcinoma. So remember, squamous cell carcinoma, if you have AK, an older patient has AK, it can turn into this, okay? And this is a little less common, it's about 20% of the time, but it's still cancer. So we want to biopsy and we want to refer this patient out, right? And the precursor to squamous cell carcinoma is AK. All right, and then here's just another picture for you to compare squamous cell and basal cell, just how different they can look. Yeah, at the same time, a little bit the same. All right, so now let's talk about this patient that comes into you. And they have this on the body. It's symmetrical, and there's irregular borders, and the color's changing. Diameter, it's more than 6. It's just changing, evolving, and it's elevated. It's just not looking normal. What are you thinking? Well, hopefully you're recognizing this and you're thinking melanoma, right? Melanoma, this is the most deadly of them all. So definitely, again, biopsy, refer them out quickly. All right, so now this lady comes in and she's like, oh my God, I'm having heart palpitations and I'm short of breath. What's going on? You do an EKG and you see this. What's going on? Well, hopefully you can recognize that this is AFib, right? Typical AFib, textbook of AFib, beautifully irregular, no P waves. So now this patient, comes in and they're sitting and you're looking at their eyes and you see all these deposits on their eyeballs, or I should say on their eyelids or surrounding the area. What do you suspect and what would you work them up for? Well, hopefully you are thinking, and I can never pronounce this, xanthosoma, okay, the X word, and you would order a lipid profile. You want to check their lipids, okay? This is not, I shouldn't have that there. You're worried about their cholesterol. And speaking of cholesterol, make sure you guys know your cholesterol levels for the exam. So you know your total, you know your LDL, know your HDL, all those fun things, and how to treat it based on those guidelines. Okay, so know how to treat it. Like, how would you treat somebody with high intensity medications? Okay. Since we're on this topic, let me ask you this. If a patient comes in and their ASCVD risk factor, 10-year risk factor is over 7.5, and they're a smoker and they have COPD and diabetes, they just have it all. What would you treat them with? What would you prescribe? And the labs are abnormal. Yeah, hopefully I paused as you guys are live here. I'm waiting for you to answer for some reason. So hopefully you're thinking high intensity medications, right? Because that's what the guidelines say. So follow those guidelines because you might have one or two questions like this. And what are those high intensity medications? There's only two in that class, right? So there's atorvastatin, 40 to 80, and there's rosuvastatin, 20 to 40, okay? So Lipitor and Crestor are the only two in that class. Okay, let me ask you this. When should you screen for lipids? What are the guidelines? Okay, so you should start at the age of 20 and do it about every 5 years. And then at 40, maybe every 2 to 3 years or so, okay? And obviously, if they have risk factors, obese, and all those things, abnormal labs, you are going to do it differently. All right, let's move on to some ear stuff. So patient comes in and they're complaining of some discomfort and fever. And you look inside the ear and you see this bulging tympanic membrane staring at you. Just perfect, textbook perfect. What are you thinking? Well, I hope you are thinking acute otitis media. Thinking ear infection, right? And what is the first line treatment? How would you treat this patient? You would give them some amoxicillin or Augmentin. Amoxicillin or Augmentin, right? Yeah. Macrolide if they're allergic. All right, so now this patient comes in and they have this complication of an ear infection, okay? Maybe they didn't finish their antibiotic and they show you there's this redness and warmth and pain behind their ear on that mastoid bone. What is this? Well, hopefully you can recognize this. And this is mastoiditis, right? Mastoiditis is basically an infection of that bone, and it's a complication of ear infections and sometimes when our people don't take their medications, okay? So be familiar with that. Well, basically be familiar with all the topics I discuss here. All right, so this older patient comes in and they also have a history of multiple ear infections. And you look inside their ear, you're doing your thing, and you see this cauliflower staring back at you. What are you thinking? What is this? Well, I hope you are thinking that this is a cholesteatoma. Cholesteatoma. That's not an easy word to say. And what are you going to do about it? Are you going to take your little scooper and scoop it out? Or are you going to refer them to an ENT? Well, hopefully you don't want that cauliflower yourself and you're going to refer them so somebody else can fix them, right? And what type of hearing loss would this patient be experiencing? Would it be conductive or would it be sensorineural? Conductive, right? Conductive. That's what our little cauliflower is. If you don't know your Weber test, I do have a little video on YouTube, so I'm not going to go deep down into this, just how to do it. The YouTube thing is down there. But let's quickly talk about conductive versus sensorineural, and about the Weber. Just remember from this slide that normal Weber results is no lateralization, so there's no problem. So normal, no lateralization, no problem, okay? If you see that type of question somewhere down in the future, check out that video. But let's talk about conductive versus sensorineural. Okay, so how do you remember which is what? Conductive, basically, if you do an ear exam and you look into their ears and you can see the problem, that's automatically conductive, okay? So they have lots of wax, they have a button in there, they have an infection, they have that cauliflower we discussed, that's conductive. If you look into their ear and you cannot see the thing that's causing their hearing issues, then that is sensorineural. So everything else that is listed on here, Meniere's, all those things, as you could read. All right, moving on. All right, so patient comes in and they're complaining of itching and fullness. And you guys, this is not an anus. Okay? Some people think this is an anus. But they're complaining of itching and pain and fullness and some decreased hearing in their ears, obviously, and they love to swim. What is this? Yep. Again, otitis externa, right? Otitis externa. And how would you treat this? Would you give him some oral antibiotics or would you do some drops? Well, hopefully you said you would do some topical drops, something like a little bit of Cipro with a steroid to help with that swelling, right? One more ear question and then we'll move on to something else. Let's say a patient comes in and they have a ruptured tympanic membrane. What would you do? How would you treat them? Hopefully you wouldn't do really much anything. You would just let them heal, okay? You let them heal. You're not gonna freak out and send them to the emergency room. You are just going to let it heal. So don't choose the wrong answer. All right, so now this dude comes in and he has a red strawberry tongue and swollen hands and feet are swollen too, and there's a fever for longer than 5 days, and it's really high, like in 104s, and the skin is peeling from those hands and feet because it's so freaking swollen, okay? What does this kid have? What are you thinking? Well, I hope you are thinking Kawasaki disease, okay? Kawasaki disease. And this is a type of vasculitis, so it can affect the heart vessels. And how would you treat them? Yep, if you said high-dose aspirin, yes, you are correct. We do not care about Ray's syndrome. We are going to give him some high-dose aspirin, and we're going to send them out to the emergency room. And they can do something else too, like IV immunoglobulin. All right. This dude comes in, and the mother tells you that he's been having a high fever and a runny nose, and he developed this slap cheek rash on the face. And then it spread, kind of lacy pattern, okay, to the chest, to the trunk, and the extremities. What is this? Fifth disease, right? This is the typical signs and symptoms of fifth disease. It's viral, it's self-limiting, it's really no big deal for this little dude. However, it is a big deal for someone else. Who is it a big deal for? Well, if you said someone who's pregnant, maybe his mom was pregnant, you are correct, okay? So, because it can actually lead to miscarriages. All right. So now, this patient comes in to see you, and they have a strawberry tongue, and a sore throat, and swollen interior lymph nodes. They're just not feeling good, and a fever, and you are weird, so you want to just touch them all over. And when you touch them, you feel this rash feels like sandpaper, okay? So this rash feels like sandpaper. What is this? Hopefully you know that this is scarlet fever, right? Scarlatina, scarlet fever. And how do we treat this patient? Amoxicillin, penicillin, right? Strep is what causes it. And if you have to, macrolide is an alternative. All right, so this young person or old or whatever comes in and they're complaining of painful, their eyes are painful and they're crusted and there's all this junk in there. And it started with one eye, then it moved to both. What are you thinking that this is bacterial or is this allergic conjunctivitis? Is it bacterial or allergic? Well, I hope you are saying bacterial, right? All those are those typical symptoms of bacterial. Quickly, let's talk about bacterial, viral, and allergic. So bacterial, just remember it's purulent, gross, crusty, red, just bad looking, okay? And it starts with one eye, and then because it is contagious, it can move to the second, right? Viral is usually starts with one eye as well, but it's more teary, more clear discharge, not as nasty as bacterial. And again, one eye, and because it's contagious, it could spread to the second eye. And then finally, allergic. Allergic is usually always bilateral. Makes sense if you think about it, right? Could be a little stringy, but it's bilateral. All right. So, what is black pen used for? Well, I hope you said it is used for ocular eye infections. Okay, so when you see your patient come in on your exam, because you know your patient's going to come in during your exam, and you see a nasty eyeball with crusting, swelling, redness, you're going to prescribe them some Blab 10. Yep, that's what you're going to do for your patient. Okay, moving on. So, don't forget simple things too, like knowing where your things are in your body. Let me ask you this. In what quadrant can you find diverticulitis? Left lower quadrant, right? And what's the best test for that? CT scan, right? CT scan. What about, in what quadrant can you find your appendix? Right lower quadrant, right? So if a patient comes in complaining of signs and symptoms of appendicitis, what test would you perform? A CT to confirm it, okay? A CT, not an ultrasound, a CT is what you would choose, an exam, okay? And just be familiar with different advanced assessments for appendicitis, right? Like McBurney's and, you know, all those. So go through the list of all the advanced assessments for appendicitis. Sometimes they come up, sometimes they don't. What about if somebody comes in and you're suspecting cholecystitis? What quadrant? Well, I hope you're thinking in the right upper quadrant, right? And what diagnostics test would you order? An ultrasound. An ultrasound you would order, okay? So be familiar with these. All right, let's talk about a little more GI stuff. So let's do this matching question. And since you guys can pause me now, pause me and I'm not gonna pause. And so on the left side, we have the diseases, and on the right side, we have the results. So you're just going to match IBS, IBD, and C. diff with those results. Pause me. Now I assumed you paused me, and I'm back. So I'm going to tell you. So IBS, irritable bowel syndrome, right? You would have negative white blood count. You would have no inflammation. You would have negative CRP and negative ESR, right, or set rate. Okay, so that's what that. Be familiar. This is what you will expect to see on the exam with matching questions. Okay, now IBD. And IBD we know is Crohn's disease and ulcerative colitis. The results would be positive white blood count, positive CRP, positive ESR. Obviously, they're going to have some inflammation as well. And then finally, C. diff or pseudocolitis, positive white blood count, negative CRP, and negative ESR. Okay, So when you have these type of questions, don't freak out. Take your time, think through it so you get the points correctly. Okay, and what would you work a patient up for? If the patient came in with diarrhea, what would you order? What should you order for them? Well, stool culture. You should order if they're complaining of some kind of diarrhea. CDC, CNP, ova, and parasites. That's where you should start to work them up. All right, let's do one more GI question. So a patient presents to you with bloody and mucousy diarrhea. Which is the most likely diagnosis? And put these in order. So pause me and put these in order. All right. So I hope you said that IBD would be first, or UC and or Crohn's. Those are typical bloody mucousy diarrhea. And then I hope you said C. diff. And then I hope you said dumping syndrome. I do like dumplings. So that is the correct order. All right. Briefly about GERD, because everybody freaks out about GERD and first line, right? Because in one book they read PPI, and the other they read H2 blocker, and the third they read lifestyle modifications. What are you going to choose on the exam? You'll figure it out, okay? So if a patient comes in and they're complaining of those signs and symptoms of GERD, they've documented GERD, or tells you they have GERD, whatever, hoarseness, recurrent cough, all those fun things, how do you treat that patient? Okay, so one, you start with educating them. You educate them about lifestyle changes, diet modifications, right? They should avoid acidic foods. They should avoid caffeine. They should avoid chocolate. All the things that are really good for me, they should avoid, okay? Then if that doesn't work, you're going to put them on some kind of anti-acid PRN or H2 blocker, okay? If that doesn't work, then you're going to put them on a PPI. And if that doesn't work, you're going to refer them, or you might be referring them a little bit earlier already. But if you keep that order in your mind, you will be okay. So when you have this type of questions on the exam, do not freak out, read the question. Because if it tells you that they've already tried an H2 blocker, you're not going to choose an H2 blocker to prescribe again. You're going to go one up, okay? So sometimes people have just a simple where it says, what is the first line for GERD? You're going to choose H2 blocker. But if they tried it, you're going to try out PPI. Hopefully that makes sense and clarifies it a little bit for you guys. Okay, let me ask you this. What hypertension medication should you avoid in patients who have GERD? Calcium channel blockers. You should not give your calcium channel blockers to our GERD patients, because if you think about it, right, it relaxes everything, right? It relaxes your blood vessels, it slows everything down, and it can make GERD worse. So we try to avoid that. And there's also some drug interactions. Some GERD medications have drug interactions with calcium channel blockers. Okay.